Hello everyone, and welcome to our roundtable, Glaucoma and the Pandemic, a surgery-led approach. This virtual event has been organized by the Ophthalmologist. Our headline sponsor today is Allergan, and the supporting sponsor is Nova Eye, and we are very grateful for their support. My name is Alexandra Jones. I'm the editor of the Ophthalmologist. I'm delighted to welcome this amazing panel of glaucoma experts, including Miriam Kolko, Professor in Translational Eye Research at the University of Copenhagen and Chief Physician at the Copenhagen University Hospital in Denmark, who will be moderating today's discussion. Anthony Khawaja, Consultant Ophthalmologist at Moorfields Eye Hospital and UCL Institute of Ophthalmology in London in the UK. Kaweh Mansouri, who is a glaucoma specialist and Consultant Ophthalmologist at Montchoisy Clinique in Lausanne in Switzerland. And he also works at the Department of Ophthalmology at the University of Colorado in Denver in the USA. And last but not least, we have Constance Okeke, glaucoma specialist at Virginia Eye Consultants in Norfolk in Virginia, USA. Now let's get started. I'll pass it over to our moderator, Professor Miriam Kolko.
Thank you very much, Alexandra. I'm pleased to moderate this fine session. And the session is about glaucoma and the pandemic. And there is a lot of questions that arise speaking about the pandemic. And I'd like to start out with the first question that I'd like to ask the panelists about. And for this question, Anthony, how do you think that glaucoma management has changed since March 2020?
I actually think a lot of the way we're managing glaucoma now is maybe in part ways we've been aspiring to. We've been forced to transform the way we care about patients. Obviously, of course, we would like to see everybody as often as we previously used to, but we always knew that with the aging population, our current way we manage, our previous way of managing glaucoma patients wasn't sustainable. And I think we've all been forced to transform and change the way we manage. So that is maybe what we call virtual clinics, other people call telemedicine, where actually a patient just has their data collected and doesn't see a doctor or a physician at that point, goes home, and then there's an asynchronous review of that data, and then somehow contact with the patient either by letter or phone call. So I think many of us have moved on to that, and really enforcing risk stratification. I mean, that's something we used to always do, but we kind of still always did all the tests fairly frequently, even on our low risk patients. And now we've obviously been forced to change that. So we're really applying risk stratification on force. I think, I mean, I don't know how much you want me to talk now, but I think we've changed our surgical strategies slightly and taken into account what might be have less impact on the amount on how intense follow-up is required. And I think we've all been encouraged to go more digitally. So to enable en masse risk stratification, enable virtual clinics or asynchronous review, we need to move more to electronic medical records and digital ways of working. So I think those are the main ways a lot of us, I think, have changed since March 2020.
Yeah, well, it sounds very interesting. You are actually answering a lot of the questions, but we'll go more in depth into those later on. So Kaweh, has it really changed your way of managing patients, the pandemic?
You know, Miriam, I think countries have had different strategies to cope with the COVID pandemic, have also been affected differently. And another parameter which will determine the change it had on clinics is also the density of ophthalmologists and glaucoma specialists. Now, of course, we all had the first lockdown phase where in the UK, in Switzerland, in Denmark, I think in the US, we ceased all non-urgent and emergent clinical treatment, which means 95% of our glaucoma patients fell into that category, and we asked them not to come to the clinic for about 6 or 7 weeks before things restarted slowly, and we tried to work up that backlog. Then we had the second wave, which according to which country you're in, you're out or you're still in, and some countries are going to the third wave. However, those medical restrictions, not to only urgent, emergent, were not imposed in most countries, such as mine, Switzerland, during the second wave. So we went to a new normality in glaucoma management, which means we continue to see our patients, our elderly glaucoma patients, more or less in the same frequency than we did before. But of course, with all the precautions of face masks, not having relatives accompany them if possible. And in Switzerland, the virtual clinics have not been such a hot topic already before, compared to the UK, for example, because we have a high density of ophthalmologists and we were less dependent on optometrists to do part of the work. In the sense that now we don't have them do the clinical exams with the optometrist, and then they go home, and then the ophthalmologist would do a virtual clinic to interpret with them, as is done, for example, in the UK, as Anthony mentioned. So I would say the changes which we have seen in Switzerland, in many continental European countries, in glaucoma management, in the new normality, have been less dramatic than in many other fields. You know, being based in Switzerland, I speak with my younger patients who are many of them in finance, and in finance, things have changed completely. You know, people work from home, have not been back to the office for a whole year. And that was a huge paradigm shift, because banks, you know, were insistent that you have to be in the bank to have the confidential data. And now all of a sudden, they send all their staff home. In ophthalmology, in glaucoma, and we have had incremental changes, I would say, at least in our situation. What has changed? Well, I would say, speaking from my own clinical practice, we try to do more SLTs, maybe, because if they work, then we are less dependent on patients refilling their medications. We do some calls, video calls, which is something we never did before. But in patients where we consider they might be stable, they wouldn't have to come, and they're maybe elderly, we try to discuss with them over phones. I would say maybe 5% maximum of our clinics in Lausanne are done by video or telephone calls.
I think, sorry, you go ahead.
But other from that, I would say largely we have gone back to practice in the same frequency that we worked before. And I think we will go into other details of different innovations that we are going to introduce hopefully soon. I won't anticipate that yet. So
actually, it's quite exciting to hear already that Anthony and you, Kaweh, are actually experiencing the pandemic in different ways due to the different circumstances in the two countries, and I think that's quite interesting. And I'm excited to hear you, Constance. So how have you felt how do you think the management of glaucoma has changed, or has it changed in your hands?
Well, there's been a number of changes, as the panelists have already mentioned. There's been a change in how we had to approach patients, because either our clinics were closed to the volume of patients coming in, or patients weren't comfortable coming in. So we had to try to find ways to still reach out to them and manage them. And so for the first time, we introduced in our clinics using telemedicine in the glaucoma. We also used it in other areas of post-cataract surgery, eliminating post-op day 1 visits by using virtual visits. But we also used it in glaucoma, and that was a completely new model. So we used a hybrid technique of patients coming in specifically for diagnostic testing, so we can try to minimize the amount of time that they were in the clinic, coming in, getting your tests, going out, and then using the follow-up model of a virtual phone call to review those tests along with their medical record, and to assess whether they were stable or if there was need for intervention, whether a change in management or coming in for a certain laser procedure, or you need to come in because I need to see something because something has changed. So that was new, and that was some challenge to implement in a practice that has multiple doctors with multiple different practices going. And so there was some challenges involved with trying to get that going. What I also noticed that was happening in my patient population is that the realities of glaucoma being a very disruptive disease was very relevant to me, because there were a number of patients who were coming in, having missed appointments, having just run out of medications, not communicating, and just assuming that things would be fine when they push off coming in eventually, and then finding out that their disease progressed substantially. And so I was doing a lot more surgical intervention in order to make up for the significant disease that was happening and trying to get things under control. So I think that one of the things that I come away for is just even more understanding of the importance of educating our patients. We can try to do surgical management to try to take certain things out of their hands, but the importance of follow-up, the importance of being able to monitor if there's certain changes that are happening, and the importance of coming in still needs to be conveyed on a level that I think needs to be intensified. And that's one of the learning lessons that I'm getting from this, this pandemic experience.
You're on mute, Miriam.
I think that's a very, very important point that you say that you've experienced how important education is, since some patients have been leaving out their appointments and then they have been experiencing a progression. So I think that education is just becoming even more important after our learning lesson from the pandemic, which we're still in. And I also think it's very exciting and interesting to hear the three of you, which have actually managed glaucoma very differently. I can say in Denmark, I would say we lean up towards what Kaweh has experienced. So we haven't really seen much changes since the glaucoma patient has still been coming. However, some patients have not dared to go to the clinics. And so in that way, Constance, we have experienced the same as you, that some have progressed since they haven't been at their visits. So one question is, now we are in this this very special situation with the pandemic, and we have seen some delays. And you say, Constance, that we need to educate our patients more so they understand how important it is. Is there anything else that we can do to prevent the delay of care? I'd like, for this question, you can go ahead, Constance, with this.
I think that when we talk about education, there's the education that we give one-on-one with our patients, but if we give it one-on-one, that means they have to actually be in front of us to give it. And so in hindsight, one of the thoughts that I had when thinking about this question is trying to be more proactive in that education. So for example, we have an online portal, and we have ways in order to touch our patients via text or email to remind them of their appointments, as well as give them other information about the clinic. And in hindsight, one of the thoughts that I had that could have been very helpful was kind of flash reminders to our glaucoma patients that, hey, if you have glaucoma and you've run out of your medicines, you need to make sure you get those refilled. Make sure you call in to get those medicines refilled. Or if you have been asked to come in for an appointment and you feel uncomfortable, consider scheduling a virtual exam. So something to educate in a way where we're targeting them and we're getting out to say it, as opposed to just hoping that they know better from the education that we gave them when they were in the clinic setting before, when they were coming in regularly. So that's one of the things that I would have, in hindsight, would want to do, and maybe can think to do that in the future as a way to just encourage this education, importance of follow-up and things like that.
What about you, Kaweh? Did you experience that some patients didn't dare to go to the clinic and thus had delayed care?
Yes, unfortunately, we as well, of course, had patients who, for good reasons, I should say sometimes, didn't come to a clinic. Mostly elderly patients, maybe patients with additional comorbidities who would put them at a very high risk group for complications, didn't come to the clinic. Now, we don't have statistics because we have not really reviewed our entire database to see who canceled appointments or who delayed appointments. So I don't know how many this would be. And my fear is that we will have a delayed presentation of progressed glaucoma patients. Patients who didn't show up for, not just for the initial lockdown when we were closed, but beyond that for the last 6 or 9 months, who didn't come to the glaucoma clinic, where we would have missed potentially signs of progression, such as disc hemorrhages, which we didn't detect because we didn't see the patients, signs on visual fields, OCTs that were not conducted, so they were not detected, loss of adherence because medications were not refilled or were not taken, And once they come back to our clinic, then we will detect their past progression. Usually we try to have a system where we detect progression when it happens, or signs of happening progression. So my worry is that many of our centers will have an avalanche of delayed detected progression of glaucoma occur. In the meantime, yes, there were unfortunately a few patients who didn't show up for the first, those were high patients who didn't come for the first lockdown phase, who came several months delayed. And we had a few patients who did progress in even a short span of time. But on a positive note, as you know, glaucoma in the majority of cases is a slowly progressing disease. So missing your patient for a month or two compared to patients with macular problems should be less of a worry for the large majority of glaucoma patients. How did we try to cope with the delays that we had, especially after the first lockdown phase? Was the extended working hours, went longer in the clinic. We opened Saturday clinics, because you know, now that when we see patients, a regular consultation clinic often takes longer, although we try to minimize the time you spend in a room with a patient. But now with masks, where you often need to repeat what you said, and so on, you actually see that our clinics take longer and not shorter.
Yes. So actually, in between everything you say, I heard you say something about stratification and risk evaluation. And I know, Anthony, that's one of your things. I mean, I've heard you talk about this. Can you explain a little bit about how you would approach risk stratification of patients, and how that might help identifying those that you certainly don't want delayed care of?
Yeah, I mean, this is the issue. The way we were, you know, our services were completely stretched in the National Health Service in the UK. So now our capacity is definitely reduced because of social distancing. And so there's no doubt people are going to be delayed compared to before. And, you know, we've all talked already about patients that have come to harm from those delays, but there'll be many who will have not come to harm. And there'll be many who maybe weren't using their eye drops and have actually been better off from it because they weren't getting side effects from the drops. The problem is we don't know which those people are who are really very low risk, or those that actually, if they do stop their medications or we delay by even only a few months, are going to get worse. And so we've got to do the best we can with the evidence we have right now. And so, you know, and you need to do that on scale. Now, at first, we didn't really have the systems. You know, this is at Moorfields Eye Hospital. We didn't have the systems to, at scale, put everyone into a category. And so what we did is literally every time there was a clinic coming up, or for a month ahead, we would review every individual set of notes and make a risk stratification decision then. Based on what? Based on all of these complex things that we do every time. I feel like one of the things we do every time we see a patient is a really complex risk assessment. And one way of doing it on scale was to rely on the last person's risk assessment. So if the last person said, see this patient in 2 months, then clearly there was, for a glaucoma patient, there was something of concern. If they said, see the patient in a year, then clearly that last risk assessment, they felt that person was relatively low risk. And another trick is to look at the last follow-up interval compared to the average follow-up interval. If someone was always 12 monthly and then it got reduced to 6 months, that indicates that there was some potential change in that patient that warranted, well, let's see you a bit sooner. So it's that comparison. But moving forward, I think we do need better and more objective ways of risk stratifying. One simple way is on scale is using the visual field mean deviation. If you can export that data on your visual fields from people in your clinic on scale, then you can have that alongside each patient. And there are various other schemas. So the UK and Ireland Glaucoma Society formed a working group near the beginning of the pandemic, and we worked together on a risk stratification protocol. based on some work that Peter Shah from Birmingham had led, called Glaucstrat. And I think that, I mean, that's been previously published, and this was an iteration on that. I'm not sure if that's publicly available. It might be from our Royal College of Ophthalmologists website, but that divides people up. One of the primary things is the visual field mean deviation, but there are many other factors as well. I mean, Miriam, when I talk about risk stratification, I always say we need to do better, really, because despite all of this, I think, you know, we're still caught out, and that's why we still see patients who progress in our clinics, because we couldn't predict that. And so I do see a future where we can use people's genetic information, you know, some more complex assessments of their imaging data, or maybe some better intraocular pressure monitoring or whatever. I'm sure we're going to be discussing these things later to better risk stratify. And you know, I think now people understand that more than ever, that we really must do this.
Sure. So Constance, when you've seen your patients in your clinic, and you have, as I understand what you told before, you have actually managed not to see many of your patients, but actually been in contact with them over the phone or in other ways, but not physically. But did you, when you were managing your patients during the pandemic, did you do a risk assessment, or how did you manage this?
Yeah, there were some definitely some similarities with what Anthony was saying. Just to clarify, in our particular office, we never officially closed completely. I throughout the pandemic was going in every week in order to see patients, but we did risk stratify who we were seeing. So we made it so that we were seeing the people who were the most urgent. Same thing with surgery. We never stopped doing surgery, but we limited it to people who were more urgent. And so the same kind of concept of trying to figure out who do we really need to see. So yes, if it's somebody who's a glaucoma patient who's a suspect or ocular hypertensive, you're seeing once a year, obviously they can be pushed off to longer because the risk is much lower. We were assessing, what would happen is, for my own personal patients, I went through a process of looking through my schedule and actually trying to decide a risk modification algorithm that I could try to teach my my staff members to be able to look for. So it had something to do with, when did I schedule them? So again, Anthony, just like you, if I was going to schedule someone in 2 months as opposed to 3 to 4 months, there's a reason for that 2 months. If it's a 5 to 6 months, okay, then I'm probably thinking that they're doing fine. Another way to evaluate their stability is, have they had any changes at all in their medications? If they've had the same medications for the last 2-3 visits and you're not making any change, there's likely a lot of stability with them. And then also the stage of their disease. So if you're talking about someone mild versus someone who's severe, if someone who's severe who's been seeing every 6 months, but they've been stable with no medications, let's say they've had a trabeculectomy, their pressures are always low in the single digits or low teens, you can feel a little bit more comfortable pushing them out. But if they're advanced disease that you're following every 3 months and you've made a medication change in there, they're not somebody who you want to keep pushing off. So there are certain areas that you can use within looking at just certain basic things of the exam, their stage of the disease, the frequency of when you did schedule them before, and then any changes in their treatment pattern recently that can kind of give you a gauge if this is someone who's a red light, yellow light, or green light. The green lights can be moved down, but the red lights really need to be brought in earlier.
So would you agree that we all already did risk stratification before the pandemic, but perhaps the pandemic have emphasized how important it is actually to consider this when seeing our patients? And Kaweh, having said that, do you think that the focus on risk stratification, as I hear that we all actually have been considering very much during the pandemic, do you think that we are getting better and will focus more on this also past the pandemic?
Right. So, I absolutely agree with what Anthony and Constance said. We all have been doing, and we were probably doing more of risk stratification now. But the big limitation is that this risk stratification was based solely on human intelligence, which is time-consuming, which is maybe not structured and uniform. And we would need to have artificial intelligence ideally helping us. And if you want to do this, you would need to have a medical system which is digitalized, electronic medical records, powered with artificial intelligence, so that you can do a few clicks and then you identify all those patients who, as Anthony said, were seen every 2 months versus those that were seen annually. As Constance said, who had an advanced stage of glaucoma versus those who were simply suspects or well-controlled glaucomas. And then you would risk stratify within a few clicks by putting your criteria. This is not what is done. And this pandemic has shown us, beyond ophthalmology now, that countries that had already a digitalized and often centralized healthcare system are doing much better, such as Israel, some Persian Gulf countries, some Nordic countries, Singapore. They're doing much better in managing COVID, not managing vaccinations of COVID. And my guess is when in a year from now, these countries, when if you would like to look at how they manage other, especially chronic diseases, thanks to their digitalized, pre-existing medical health system, they were better able to do it, as we are here in my country, where, you know, at the beginning, COVID cases were sent to the central authorities by fax. Can you imagine? With all the delays and the loss that could occur with fax. We are in Switzerland, unfortunately, we don't have mandatory electronic medical health records. We are not enough digitalized. And in many countries, medicine, funny enough, it lags behind other domains in digitalizing. Although we are very innovative in surgery, we are very innovative in diagnostics, we are very innovative in coming up with new treatments in ophthalmology, but in that respect, we are not that advanced. And now we really saw the limitations of it in this pandemic, which were not obvious to us before. And I think that was a turbocharger, hopefully, to change that rapidly.
So in a way, you're actually proposing that the pandemic has made Switzerland realize the importance of digital healthcare records. It's quite amazing in this country that we don't have it in our countries. I must say we have it in Denmark, but I also think what you're saying, that it's very important to go into AI, to go into machine learning, and I know that's already going on with the UK Biobank. Anthony, you might want to tell us a little bit about that, and if you see any correlation between could the pandemic affect the speed that you want to do AI or you want to learn with all the data you have in UK Biobank? Is that an innovation, or can you explore, elaborate a little bit about this?
I mean, the UK Biobank currently is a cross-sectional study, really, in terms of the eye measurements. There is some data linkage that's happened. And in the UK at the moment, the only sort of national eye healthcare related data that you can link to is related to how hospitals bill, and hospitals bill for procedures and inpatient stays. So actually within UK Biobank at the moment, we can't really look at risk prediction because we don't have that detail of that level of longitudinal data. But really, if we're ever going to be in a place to do this, then we do all need to start collecting data in a digital way. And that in some ways could be as simple as everyone going on an EMR, but we all know electronic medical records, EMRs, collect data in different ways. And so if you wanted to look at change in medications, if everything's coded differently in each different EMR, you then can't compare across different systems. So it's actually quite, there are lots of things that we might not initially think about when we think about digitization, but one's an electronic medical record, but two's how you define the fields that you need and how you talk the same language. And there you're talking about terminology, you're talking about SNOMED International, things like that. Then you need to have an agreed risk stratification approach. What tends to happen with risk stratification is Nobody takes somebody else's one and sees whether it works in their data. They just try and derive their own one, which they think is better. And so you end up having lots of different risk stratifications all over the place. So I think if we are going to crack this, we need to work together. We need to, even if it's using different systems, collect the data in the same way, somehow work together to develop something as a consensus, using the supranational societies to come up with a consensus way of finding a risk prediction model and then validating it across the world.
It's interesting that you say that, because actually the pandemic has shown that the world can actually reach consensus in a very short timeline. So perhaps we could learn from this also within stratification in ophthalmology, that it actually works. So I'll leave you then. But Constance, do you, so it seems to me that you actually have done a lot which you could compare or even is telemedicine in your clinical practice. Do you think that this way of approaching and consulting the patient will stay after the pandemic?
I think that in certain clinical scenarios, it can stay. What I found to be most beneficial for patients who worked well with the telemedicine model were, well, if a patient was not going to come in at all, it's better to get something than nothing. But I felt that it was really advantageous for patients who were on the early to moderate controlled side, or glaucoma suspects. So for example, in my clinics, I have a kind of two visit model to evaluate a new patient because of all the testing that we do. And if we could eliminate one of those visits with a telehealth visit, because of the patient having gotten a good portion from the first part and then just needing the second testing and review on the second part. That's something that easily could be done with telemedicine. And it was very convenient for the patient so that they can get in and out. Usually those patients tend to be sometimes younger patients who are working, and being able to have a fast visit in and out was very convenient for them, and they were very appreciative of that. I think that also for patients who are very stable, people who have, like I mentioned, have had the same medication, not a lot of changes, to just need their regular checkup. They don't really have any problems. They're just coming in because they've been told to come in. Those patients can come in quickly for their test. Maybe those are the every 6 months, every 4 to 6 months type of patients. Maybe every other visit is an in-office, or another visit is a telemedicine. But it is something that does have to work for your office. There were some, with the pandemic, some of our issues had to do with staffing. We had some shortages of staffing. And so even though I wanted patients just to come in for their quick test, if we're short on staff in the diagnostic testing area and we need to use those for the patients that are in office, that could create a problem for a certain practice. So it kind of depends on the practice model. It could work, but sometimes management issues might cause there to be some challenges. So I do think that because of the way that it did work in some patients, that there is room for it to be continued. I do know that some people used a hybrid model. When I saw my telemedicine clinic, I could see that those patients from home. There are some doctors that I know who did a model where they were seeing some patients in the clinic and then paused to see some telemedicine at the workplace. So there's a number of different ways that one can incorporate telemedicine to the practice. I definitely think that for for example, I mentioned our model with the post-ops of just straight cataract surgery. That has been very successful. That's something that we'll continue to do. So I think that there is room for continuation of it. It just has to fit your practice. So yeah.
So another way telemedicine, as I hear you say, can be part of the way we manage glaucoma patients, but for certain patients, and particularly the advanced glaucoma patients, it may not be the best model. Whereas the ocular hypertensive patients and the early glaucoma suspects, then it might work. But Kaweh, having said that, I know that you have been very much involved in measuring the diurnal intraocular pressure. So how would you manage that if you were thinking about telemedicine? And do you think that telemedicine will have a place in the management of glaucoma more now after the pandemic, or late stage pandemic, hopefully?
Okay, so that's a complex question. So you need to give me a few minutes. There are different aspects of telemedicine and glaucoma care. First of all, yes, as everybody else during this lockdown, repeated lockdowns, we provided some kind of telemedicine component to our patients. You know, some clinics had drive-in IOP measurement and so on. The problem right now is that in order to manage glaucoma, you need at least 3 parameters. You need to measure IOP reliably. You need to have visual field measurements, examinations. You need to have fundus examination and or OCT or fundus photography. These are 3 basic components which we need to manage glaucoma well. And none of them really can be done easily and consistently from home. IOP is probably right now the easiest to address because we already have home tonometry devices, but they are not widely available. And not every patient is able to measure correctly. Different studies have shown that at least a third of glaucoma patients, despite previous training, is unable to obtain reliable IOP measurements at home. Now, speaking about IOP, there are sensors in Europe. We have the iMate Intraocular Sensor, which is approved, which has been used for several years. This is a sensor that you implant in the eye during cataract or glaucoma surgery, and then it stays in the eye for the lifetime of the patient. And patients can obtain at-home measurements whenever they wish with an external device, which is then transmitted to the physician. And this is something that proved to be useful during the pandemic. We had between different centers in Germany and our center in Switzerland, one center in UK, in Edinburgh, about 70 patients who had this sensor in their eye. So we did a study when we went back to the investigators and asked them how those remote IOP measurements during the first lockdown period, how useful they were. And we published the data in Ophthalmology Glaucoma recently. In a nutshell, essentially, all the investigators found that the data to be very useful for those 6 weeks where they couldn't see their patients, in the sense that, first of all, they saw that some patients had their their target IOPs respected, so they could reassure the patients. So that was good for the patient's quality of life and avoiding unnecessary visits. In other cases, they saw that the target IOP was not respected, so they could either send additional drops by mail, or in some advanced cases, they asked the patient to come to the clinic, and some of them required surgery, even within that short period of time. So it provided and proved to be quite useful. Now, IOP is one component. You need visual fields, you need OCTs. And I was very pleased during the latest Glaucoma 360 meeting a month ago that there were different startup companies from the US, from India, that provided approaches to obtaining visual fields or fundus photography or OCT from home, which are almost or already able to be used by the patient. I think now, in conclusion from my side, I think tele-ophthalmology made a few jumps ahead in a short period of time, will be here to stay, but in order for it not to be a mere replacement in lockdown periods, we would need to have access to remote home monitoring of those parameters. And even then, my guess is that it will not replace a regular office visit, because there are 3 components that make office visits unique. Patients like to see their physicians in person. There are some interventions that can be done right away with there, so it can avoid unnecessary virtual plus clinic visits such as SLT or some suturalizers. Second, physicians like to see the patients in real, at least most of them, I would hope. There is a contact that you develop, especially in a chronic disease such as glaucoma. Your patients become your friends, become your family, and so on. And this is hard to keep merely virtually. And then the last one, probably the most important one as well, is education of fellows and residents. You may be able to do virtual clinics, but how do you teach your residents or your fellows to examine the patient correctly on Zoom? You can't do it. So for teaching purposes, that's very important. And speaking of which, I think we should really acknowledge what a horrible year this has been, not for us senior glaucoma ophthalmologists, but for our younger colleagues who have 1 year or 2 years to spend for the training in glaucoma. And this year was cut, the surgical training was cut, the patient visits were shortened because we are supposed to spend less time with the patient explaining and discussing. And all the education conferences, congresses, seminars went virtual, which reduces the quality for the fellows, residents, and all the networking abilities that they would have to speak to senior colleagues is gone. So I think this is a big loss which which we cannot make up for at least for this generation of COVID fellows.
Thank you for mentioning that. I think that's a very important point, that it's not about us really, it's about our younger colleagues that and in that aspect and I think that at this stage, what I hear you say, and I also like your comment, Anthony, is that telemedicine might be good in some ways. And I also think that we have to remember that the four of us are in very privileged countries. So the whole picture is very different in less privileged countries where they might not have access to physicians. So I certainly agree with your point of view, Kaweh, that it's an ideal situation that you see your patient, but in reality, I think that telemedicine might be an advantage in other places in the world. With that said, Anthony, I'd like you to comment on telemedicine and how you see telemedicine just before we move
Just
on.
one comment before I forget. You know, I think this is a terrible time for people. I think of university students, you know, the best time of your life, and you know, they're now, rather than being out there, they're at home doing their degrees on Zoom with their parents, which I mean must just be horrible. For our fellows though, actually, for a while they went through a period with very little, but then as the really urgent cases came in, it meant our lists had fewer patients on, but with, you know, juicy glaucoma surgery, if you want to call it, and more time for them to train. And I actually think the fellows that have been through with me recently have probably done more operating they would have done otherwise, when we had a really busy list and it was like, okay, I'm going to have to do this to make sure we get the list finished on time. So you know, I definitely think we shouldn't underestimate the effects on training, but I think certainly for glaucoma specialist training, the fellows have done all right. It's maybe the more junior people who need cataract surgery, for example, that's been quite majorly affected. Now, going to telemedicine, so I think we somehow have to be careful about what we mean by telemedicine, because in some parts of the world, telemedicine means, you know, the people that need the care are here, and the specialists that can provide it are here, and they neither can travel to each other. So you're going to be able to provide that care remotely to those people. Whereas what we're talking about at the moment, like we're doing at Moorfields, is we've got patients that might live around the corner from the hospital. It's not that they can't come in or that we can't, but that the mismatch between our capacity and our resources and the need is so big that we need to deliver care in a different way. And so they might still come to the hospital, but spend less time there, have a more efficient run of examinations and leave. And then we review the notes later. And then, you know, in a session, we can see so many more patients. When we see the low risk ones, we don't even necessarily phone the patient, and we can generate a letter quickly and send a letter. Kaweh, it's great that all your patients want to see you. I don't know what the evidence is that my patients want to see me. I think a large amount of them would be really happy if I told them, you are so low risk that I don't even need to see you in person. I think some people might actually feel less stressed and pleased that they don't have to see me. The other thing is, yes, I want to see all my patients, but you know, prior to the pandemic, you know, the Monday morning clinic I share with my colleague Harry Jairam, we'd have, you know, over 160 patients in one day, and actually then, you know, when you see a complex patient and you don't have the time to spend with them, it's really bad. So the patients that I really want to spend most time with, if by these alternative models of care, you can see those low risk patients, and then you get the gift of time in your main clinic, so that the patients that don't need to see me don't, and they're probably better off that way anyway. The ones that do get more of my time so that we can discuss. again, I think it's a different thing. It depends how stressed your system was before. I think in the UK, we were really stretched. Coming up to the year before the pandemic, there was a really high profile case that turned into like one of the biggest legal payouts because of what happened. And basically a fairly young patient became blind due to delays in her follow-up. And it got fully investigated on a national level. And one of the main reasons they found for this happening was that services were overstretched and that lots of people were being delayed. And then when they were being delayed, we didn't know which of those were high risk and actually, no matter what, shouldn't be delayed and should come in. So I think these, whether you call it telemedicine, whether you call it virtual clinics or asynchronous remote review or whatever, I think in the UK, these models are here to stay. Can I also, sorry, I've talked a lot, but can I pick up on another thing Kaweh brought up, which was IOP?
Yeah, but I'll come back to that if I may. I won't forget, because I'd like to conclude a little bit, because I'd like to conclude that what I've heard all of you say that is that, first of all, we are dealing with different systems. We are all in this in this round in privileged countries, but so telemedicine or whatever we want to call it can be used in different ways. But I think that we can all agree that to a certain extent, it's here to stay. Then also the patients that we see in our clinics, it's nice that we see our patients in person, but as I also hear you say that risk stratification is very important, because we need to prioritize our time. And I think that's also independent upon the systems that we're in. So I think that we can agree on that as well. Now, having said that, I'll come back to diurnal IOP measurement and how that might help us in the risk stratification. And I think that Kaweh, and then I'll come to Constance, and I'll end up with you, Anthony, so you can also comment on that, because Kaweh, you also touched shortly upon it just before, but what is your opinion, and what do you think the importance of diurnal IOP measurement is in risk stratification?
I think it's very important, Miriam, and you wouldn't expect me to say anything else, but I think it's very important. Let me tell you why. You know, we published just last year of Ophthalmology a study where we looked using, again, the intraocular sensor, the MIGS sensor. We had access to about 110,000 IOP measurements over several years from about 25 patients. So not that many patients, but a lot of data from each of those patients. And we looked at the short-term variation of IOP, short-term defined as 3 months, and then long-term, 1 year and beyond. And we found that even the short-term, 3 months is often the difference between 2 visits or so, let's say. IOP is only moderately reproducible. And in the longer term, so 1 year or more, it's not reproducible at all. The variation is huge, which shows that our current way of measuring IOP is really insufficient. And it's surprising that despite that, we still managed to control a big chunk of our glaucoma patients, despite all the shortcomings of our current measurements. But we could probably manage our patients even better if we had access to more data, to nighttime data, to data which is in relationship to patient activities. Some patients have interesting activities, others don't. And their interesting activities may have an important effect on their IOP, which for a patient-centric glaucoma management should be taken into account, or for risk stratification should be considered. And we also saw, and this is a published paper that is not published yet, when we looked at the effect of glaucoma medications on long-term continual IOP, we see that different classes of medications have distinct effects. We already knew from sleep laboratory studies, for example, that prostaglandin analogs have the strongest effect on reducing mean and fluctuation of IOP during the nighttime, whereas the other classes have not or have very little. But now, having more data, 100,000 plus data points, we see that during different parts of the day, early afternoon, late afternoon, there seem to be distinct differences between those 4 usual medication classes that we use in glaucoma. And again, these are data that can help us have better patient-centric glaucoma management. And I'm hopeful and optimistic that this will become routine care in the not so long future.
Constance, do you, a direct question, do you use diurnal IOP measurement in your clinic, and then do you particularly use it as a risk stratification method?
I use diurnal curves. There will be times when I'll have a patient come in who will stay over the course of the day or come in at various points of the day in order to assess the pressure measurements. If I've had either maybe major shifts through the day, or just there's type of glaucoma, it's maybe like a normal tensive patient, I really want to understand where their pressure fluctuations are. So I'll use diurnal curves, but I won't say that it's a heavy part of my clinic, because I won't say that I use the diurnal curves on, say, like a daily basis. Someone's getting a diurnal curve. I don't use it that much. I would like to be able to have that kind of information. It's part of it is because it's inconvenient for the patient to come in and do that. But I think that information is important. I'm excited about the work that Kaweh is talking about, because it's very necessary. We just get 1 point in the day. I had done some research with the prostaglandin travotan Z and compliance data, looking at a device that measured pressure measured when they took their eye drop, and compliance to see how often they were doing it. And when we were looking at that data and seeing how it correlated with actual drop in eye pressure, there wasn't a good correlation. We know that eye pressure doesn't correlate well. It's an indirect measure of glaucoma. That's why we have to focus on the optic nerve. That's why I always counsel my my optometry colleagues. I work for a lot of referral doctors. It's not just about the pressure. You can't just look at the pressure and say, okay, you're fine. You actually have to look at the nerve. You have to review the visual fields in the OCT every visit, because you have to see that there's some type of stability. So don't just get fooled that it's just a pressure measurement and they're at target and everything's fine. You have to look at the end organ damage. So I think that the data will be very welcomed, but we'll have to figure out how to use that data and how to concise it, because it's a lot of data to go through for one individual patient. I think it will be very helpful for us to evaluate it. And I think that artificial intelligence will be very helpful to look at certain strategies or algorithms of how we can see patterns with all that data, because it will be a lot to go through, but it's important. And I'm very excited about the work that's being done.
I think we can agree on that. And it's not going to be the only parameter, but it's going to be a parameter within the stratification. So Kaweh, you also had a comment on IOP measurements. No, sorry, Anthony. Sorry, Anthony. You can't see that I'm looking at you. I'm actually looking at you at the screen, Anthony.
So, I've been discussing this with a few colleagues, and we've all had this experience. And I think before the pandemic, we used to be of this kind of idea, it is all about the end organ damage. It's not really about IOP. Don't just change the management because of the IOP. If someone's not progressing and their IOP is a bit higher, just don't change anything. If they are progressing, even though the IOP is low, you need to get it lower. And so the IOP, not so important. And we've all changed our minds. And, having these enforced delays and seeing these people coming in later now has taught us about the natural history of glaucoma. And unfortunately, we've all seen patients that have come to quite significant harm. One of my patients essentially went blind in his only remaining eye. He was too scared to come in. He didn't even contact us. And actually, when we reviewed his notes, we weren't that worried about him because he'd been stable for a long time and his pressure had been stable. When he came back in, he basically had an unexpected pressure spike. And when I've talked to other colleagues, these people that have come in, that have come to harm, there's a really high proportion of them, they've come to harm because of an unexpected pressure spike. And so actually we've sort of changed our minds and now think, well, actually IOP might be the most important thing, especially if you're going to pick up people who are going to get worse quickly, because it might be those people who have unexpectedly gone way out of range with their IOP. So to that end, because of our huge backlog, we now have clinics which are literally just visual acuity and IOP, which pre-pandemic, we would have all gone, are you absolutely crazy? But it's basically that or nothing when you've got such a big backlog. And actually that's been, I think, a really good way of maybe identifying people at risk of going downhill very quickly. In terms of diurnal curves, I haven't been doing them very much. They do take time. And then if you look at Kaweh's, recent elegant paper that's been published, well, one day just isn't enough. One day may not reflect the 2 days previously or what's going to happen later. I'm quite interested in the water drinking test. I don't know whether, somehow giving somebody a challenge and seeing how well their outflow can cope with the challenge and seeing where that spike goes up to. I don't know if, I don't really know of anyone incorporating that into their routine into their routine clinical test. You've tried it, yeah.
Yeah, we tried it, but and I think it's quite interesting too. We didn't try it systematically, but it did seem to increase the pressure a little bit. Anyway, due to time limitation, I think that it's very important to speak about IOP and recognize that even though I totally agree with you, Constance, and everybody here, that it's certainly not enough, then it's still the major risk factor, and it's still the only factor that we can actually treat. And having said that, we have a lot of new tools to treat the pressure, and that comes with MIGS. And so I'd like to ask you, Constance, that if you are using MIGS, how do you see the MIGS might reduce the need for frequent visits? And have you done more MIGS during the pandemic?
Yes, in terms of MIGS, I have, over the last decade, just continued to enhance my armamentarium with all the available MIGS procedures because I do think glaucoma is a very individualized disease. And there are different options that will work for one patient that might not work for another. And I think that as the MIGS explosion has occurred and people are realizing that people are getting more comfortable with the idea of doing surgery earlier than they normally would with our traditional glaucoma surgeries, I think that there are certain places for MIGS that really can stand out and help patients who may be struggling with their eye pressures or struggling with compliance with medications. I am not someone who would just go straight to doing a MIGS procedure over medicines or laser treatment on a patient who was not otherwise a surgical patient, say with cataract surgery. But I do see it as a first-line option for someone who maybe was recently diagnosed. I'll start them on medication, but if they're recently diagnosed with a cataract and that cataract is visually significant, I'd be very quick to offer them a MIGS procedure along with the cataract surgery with the likelihood of lowering their eye pressure, reducing their dependence on medications, whether in part or in whole, depending on their stage of glaucoma, and being very comfortable with that, and the patient also being very happy. We are in an age where we're also introducing the idea of glaucoma patients who, yes, we want to preserve the vision, and we all know that's important, but there's also something that's important with quality of life. And just like we have our cataract patients who may want to have a certain type of vision that is not just good with glasses, maybe, but with good without glasses, we also have to introduce the same concepts to our patients of being able to offer them and preservation of their vision, but also trying to acknowledge that their quality of life, how their eyes feel, is important because it's something that could be having an impact every day. So I know I'm kind of digressing with the question with MIGS, but I do think MIGS is a very excellent option. I think that it's something that we need to get comfortable with so that we can perfect it, just like we've been perfecting our traditional glaucoma surgeries for the last 50 years, and we're making some strides in trying to figure out how to have less complications and better outcomes. I think that with the MIGS procedures, there's a lot of them, but I think that if we take them one by one and work on trying to perfect our surgical technique as well as our patient selection and our postoperative management, then we'll be able to see that these procedures can actually work well in patients we otherwise would have used traditional glaucoma surgeries.
I think it's very interesting what you're saying. So Kaweh, do you think that MIGS is going to replace medicine in some cases, and perhaps even the choice of MIGS might be a choice since you don't have the time or the possibility of actually having patients visiting the clinic on a frequent basis? Could it be used in that way to postpone the frequency or the visit of the patient, or to use that instead of eye drops or medication in general for our glaucoma patients?
Well, my answer would be possibly. So, my approach to MIGS is quite similar to Constance's, and for the same reasons, to which I would add another one, which is that we have now accumulating evidence that glaucoma patients who have been operated, either standard, classic surgery or mixed surgery, seem to have a better 24-hour IOP control, fewer fluctuations over long term, which is an important factor in glaucoma management, stabilizing glaucoma, when you can reduce those peaks and fluctuations. This is something which we are seeing now. I also would posit, since you bring it up, that our mixed or surgical patients may have fared these pandemic lockdowns with reduced visits better than our medication patients. But I would also add to this list SLT patients. Patients whose SLTs are functioning probably had a similar benefit if they were not able to come. But in order to be able to check and control whether the IOP was stable, what would you need? Well, you come back to square one. You would need remote IOP monitoring to make sure, because otherwise you may be in some false security as a physician or even as a patient. So we need that to be sure. And let's add another point, so we mentioned SLT, MIGS, and then we have, at least in some countries, depot medications, like in the US, where you have Lumigan, Durista, approved at least for one injection so far, and that can provide up to a year or longer IOP control. So these approaches probably will help us.
So just with respect to time, Anthony, do you have a short comment about MIGS and how you see MIGS? Did you see the use of MIGS change during the pandemic? And do you see in general innovations within surgical methods that those can change how we manage our glaucoma population?
Okay, so but briefly, I mean, I think MIGS is broad. You've got like minor MIGS, like trabecular meshwork bypass, and you've got subconjunctival drainage MIGS, and I think that we're talking about different things here. Certainly the subconjunctival ones, maybe you're considering doing that instead of a trabeculectomy, because for my trabeculectomy patients, I like to see them weekly for the first month in case I need to take out releasable sutures and do some adjustments, and maybe some of the other MIGS you might not need to do that. But I think the evidence is still short on them. But for all the reasons that Constance and Kaweh have already said, we need to innovate surgically. And I do have this idea that maybe someone who's been surgically managed does have less fluctuations over time. I agree with that.
So just to sum up again, because I agree with you when you say that MIGS is not just MIGS, you have different kinds of MIGS, and some of them you could argue that you wouldn't or shouldn't really call them MIGS, because you are dealing with the conjunctiva. So, but anyway, when I round everything up, what we said throughout the whole session today, it comes down to that our glaucoma patients may not, well, they are people, they are individuals. They should not be treated equally. They should be treated in a personal manner. And I'd like you to comment on this more holistic view of our glaucoma patients. Has this holistic view changed during the pandemic? Has it been emphasized more that we need to have a holistic view of our patients, to treat them, to stratify them, and treat them in a personal manner. I'd like you, Kaweh, to comment on this.
Sure.
And just for the record, be short because time is running.
I think the pandemic helped us to appreciate the holistic value of the glaucoma patient better. Why? Well, because we had to make choices. Is it worth for the patient to come to the clinic, or can they wait safely 3 months or 6 months at home before they come? So that brings you to risk stratification. You need to look at the patient's age, life expectancy, comorbidities. Of course, you should not treat a patient who has a projected life experience of 5 years the same manner you treat somebody who has 30 years ahead of her or himself. And the necessity to see a patient in difficult times is different. The way you treat the patient is different. These are important points that we were hopefully considering before. I think this pandemic improves things, changes things. And one of them will be to challenge us as physicians more to consider the holistic approach.
And Constance, a short comment from you also on personalized medicine and glaucoma. Hey, you muted.
I think that the whole personalization for glaucoma is something that I guess we just need to emphasize more and more. I can't necessarily say that the pandemic made me do it more, but I know that it was utilized. Each patient is different, and there does need to be an understanding that we need to talk to our patients to try to figure out exactly what's happening, because sometimes it's as simple as the right kind of question that you ask to really get to the answer and the crux of the problem. I know that sometimes it's difficult because of the number of patients that we need to see. We can't always do the kind of care that we would like because of just time and less just too many patients to see. But at the same time, there still needs to be an emphasis that we need to talk to the patients, whether or not it's about the fact that they might not be using their drops well because the drop doesn't feel good, or they may be not using their drops well because it's too expensive and they're stretching the drop, or they may not be, just the regimen is too rigorous and they're saying, yes, I'm doing the drops, but that means they're doing 2 out of the 4. And maybe we need to figure out a way to do another procedure or give them a compounding drop or do something different. Those things need to be evaluated per patient basis. There's not a one size fits all for any one particular patient. And we have all these tools in our pocket. And so the more that we arm ourselves with the different tools, we can individualize our care to each patient.
And Anthony, now I'm looking at you again. Do you have a comment on personalized medicine and glaucoma? A short one, because I need also to ask you about a final question for my side afterwards.
All right, okay. Well, I mean, I think we all know that primary open-angle glaucoma isn't just one disease. It's lots of diseases that look the same. Some people have a problem at their trabecular meshwork. Some people have a problem at their collector channels. And, you know, we're at the moment treating all POAG the same. So I think in the future, with the help of genetics in particular, we'll be able to start subcategorizing these patients and working out who will do amazing with trabecular meshwork bypass and who you should just ignore that and go straight on to do some other different sort of treatment for those patients. So, you know, at the moment, we've got to do better than our current trial and error. And the time is now, actually. We've got the tools we need. So I think it's an exciting time.
So you're actually answering a little bit my next question, because your expectations, long-term and short-term, maybe you would start with short-term expectations, and then what is your dream? How are we going to manage glaucoma?
Right. The short-term, I mean, not very much can happen in the short term. From my point of view, I think in the short term, in the next, say, 4 or 5 years, we can start to have develop prediction models on the basis of genetics and other factors that can help us predict response to different treatments and who needs treatment. In the longer term, then these can be rolled out at scale because more and more people will be getting genetic testing just as part of routine healthcare in a way that can be integrated into a model and then can be into an electronic medical record and can then be prospectively validated, which is what we need for that to be rolled out.
And Constance, what do you have of short expectations and more long-term expectations for how we can improve?
Well, I would say in terms of the short-term expectations, I think that we need to focus on some of the work that we have already been doing in terms of the MIGS innovations. I think that we need to focus in on trying to figure out how to do them well. Just like with a trabeculectomy, we would spend time trying to figure out how to make the bleb, how to make it more diffuse, how to do the technique, how to understand the post-operative management. Well, I think we need to do the same thing for the MIGS explosion. There's been so many, and trying to pick out which one. I definitely feel like with patient selection, there are certain people who just do really well with certain types of MIGS procedures, whether it's a goniotomy or canaloplasty or stenting. There's certain algorithms of people who've been doing this more and more, who are starting to come up with certain patterns that I'm hearing are very similar. And so I think that as we evolve that and then teach it, I think that it will be more useful than just being kind of confused with the masses and not knowing which way to go. In terms of the long term, it would be really great to be able to have more information diagnostically about where the actual problem is for each individual patient, so we can target it. If we had understanding of what's happening really in the canal or in the outflow system, and then we can decide, okay, this one, we just can't even, this is not going to work. We just need to completely bypass this with some type of conjunctival stenting or trabeculectomy or something that's the decision. Or this area of concern is really just in the trabecular meshwork. If we just remove that with a goniotomy procedure, it would be better, or maybe it's in the outflow system. So something that is a diagnostic tool that allow us to be more specific so that we can get better outcomes. And then also, I know that it's not my area of research, but I'm encouraged by certain models where there is actual regeneration of optic nerve tissue. I mean, that's a concept of a cure for glaucoma. I mean, I don't want to be out of work as a glaucoma specialist, but if a cure for glaucoma was feasible, I would want that for our patient population.
For sure. So Kaweh, do you have a comment on what do you see as short term? What expectations do you have to improve glaucoma management?
I would say for the short and mid-term, I would like to have a data explosion in glaucoma. So in the short term, say 3 years, I'd like to have routine, continuous IOP data from at least all glaucoma patients who are more advanced, who are undergoing, if they're undergoing cataract surgery, I would like to have a sensor implanted. If they're undergoing glaucoma surgery, a sensor implanted. Ideally, sensors that can just be injected to have more IOP data. I would like them to have access, if they wish, to depot medications. So midterm, say 5 years, I would like patients to obtain routinely home visual fields, home OCTs that supplement their clinic fields and OCTs. And in the long term, say 7 years, I'd like to have neuroprotection, regeneration, as was mentioned. I'd like to have gene profiling for all glaucoma patients, to risk stratify, among others, to plan the surgeries, as Anthony mentioned, and so on, and have kind of a data platform for all patients where you have data from the home measurements, IOP, visual field OCT, call it the home glaucoma, and the clinic glaucoma, where they come to, in addition, they come to the physicians and more complex exams are done in the clinic. And the two would be combined on data platforms guided with artificial intelligence and machine learning. That's my wish.
So to round up, I would say that it's good for our glaucoma patients because we do have a lot of vision for our patients. I think that we all agree that we need to individualize, stratify our treatments better in the short term, but also in the longer term. And we need to collect data, and we need also to know much more about the pathophysiology of glaucoma so that we can treat patients with current medications, but also new treatment strategies. In best case, yes, we would like to cure glaucoma. Let's see when we get closer to this. And with these words, I'd like to thank you. It's been easy to moderate you guys because you've really been talking a lot, and that's nice. Thank you very, very much. Alexandra, over to you.
Unfortunately, our time is running out. I'd like to thank our speakers for this brilliant discussion. I'm sure you could keep on talking for another couple of hours at least. Many thanks again to our headline sponsor, Allergan, and the supporting sponsor, Nova Eye. If you have any questions you'd like to ask our panel, please email me directly. From everyone at The Ophthalmologist, thank you for watching and stay safe.